active surveillance as an accepted first-line treatment in most desmoid tumor cases patients. So briefly, I will be back to the start of the story. The story started almost 15 years ago with this first paper published from the French group. They show that patients who were operated with R0, so clean margin, complete excision of the tumor, or R1, meaning close margin or margin positive, behave in the same way. But they also observed that a group of patients without surgery, they didn't progress, and they had the stabilization. We then put together the patients from France and Italy, and we confirmed the previous data was the 2009. And then we confirm the spontaneous regression in a specific abdominal wall site, and also in the extra-abdominal wall. And the French group showed also that Desmoid could have the same behavior despite being in a favorable or unfavorable location. With that said, with these kind of experiences, we publish the first consensus position paper, not consensus, position paper from the Italian and French sarcoma group. It was a collaborative effort, and we stated for the first time that wait and see could be a frontline approach for the vast majority of patients with desmoid. We then publish a few more consensus, as Bernd already showed you before. The first was in 2013. Again, frontline approach, wait and see for the vast majority of patients. And then in 2017, and the last one in 2020, before the very, very last that was just published a few months ago in JAMA Oncology. With that said, in 2020, we stated that active surveillance is the first step after diagnosis for the majority of patients, and active treatment should be considered only in case of persistent progression, and we then define what does it mean, persistent progression. Because progression at the single assessment, as you can see, especially in the absence of a specific symptom, would not be considered the choice to go with active treatment immediately. Active surveillance doesn't mean doing nothing. It means that patients need to be continuously monitored with a first MRI or a CT scan if MRI is not possible, or in a specific locations such as intra-abdominal within 1 to 2 months. And this helps us to exclude the very aggressive form of desmoid, and then the interval could be 3 to 6 months, depending also on how the desmoid behave. A decision towards an active treatment should be then postponed until the occurrence of subsequent progression or increase of symptoms burden, assessed, as I said before, at least to further assessment, and possibly not before 1 year after diagnosis in the absence of RECIST progression. RECIST is the criteria we use to define the progression. So it means 20% increasing of the largest diameter. So we have a rationale for active surveillance, and there are these retrospective evidence of growth arrest and spontaneous regression, but we needed the confirmation, and so we ran prospective observational clinical studies on the natural history of this disease. And these were all European studies run at the same time. We have published in the last 2 years these 3 papers showing that the event of progression at 3 years, or the risk of progression at 3 years, is approximately 50%, and half of the patient could safely managed without a non-surgical strategy, and desmoid stopped growing. In our paper, we showed that the majority of progression were observed in the first 9 to 12 months, suggesting that the first year after diagnosis is critical. And spontaneous regression was observed as initial event in 25% and in 1/3 after initial progression. This was something surprising, meaning that some of the patients who progressed can also have regression after progression. In the Dutch study, roughly half of the patients who exhibit progression as initial event and continued active surveillance presented a secondary decrease, as we showed. And also in the French study, 2/3 of patients presented the spontaneous regression as a first event or after an initial progression. So now we also add some prospective data. And moreover, we also observe spontaneous regression in the 2 clinical trial, randomized clinical trial on drugs. The first was sorafenib, and in the sorafenib study, 2/3 of patients stabilized or presented regression in the placebo group, so patients not treated. And also in the neurogagestat study, event-free at 2 years was 44% with placebo. But there are patients who need treatment, and the question at the beginning when we evaluate a patient in our clinic are who are these patients, when to treat, and why we need to treat. The incidence of starting active treatment at 3 years is approximately 1/3, 30%, and the vast majority started in the first 18 months. So thanks to all our colleagues and also the advocacy group, we met in Milan and we published a few months ago this paper. Bern already showed this. I would like to underline that once again, the diagnosis is fundamental. Diagnosis should be done with a core needle biopsy, and the pathology should be an expert in soft tissue sarcoma, and then patients should be referred to a sarcoma centers to be treated or to receive an opinion. And in case of not life-threatening or not function-threatening or significant impact on quality of life, patients can be safely managed with active surveillance. If all the conditions mentioned before are present, patients can undergo a treatment. I'll show you just a few examples of our patients back 10 years ago, almost when we started our study. This is a female, 40 years old, with abdominal wall 5 centimeters. We observed a decrease. I don't know if I can show you, but you can see. Is there a point here? No. Anyway, it's in the abdominal wall, in the left abdominal wall, and then it disappeared in 24 months. This is another patient with a desmoid in the trunk, in the back. She's a female. She is a female, 61, 8 centimeters in the longest diameter. And she had an initial regression, but then a worsening of pain in March 2016. But the disease didn't grow, so we keep on surveillance and we started painkiller. She improved with the pain in April 2017, and disease decreased more. And this is the last. a female, 40 years old, with the trunk desmoid. The initial size was 4 centimeter. It grew, but patient was completely asymptomatic except for the mass, and she didn't want to go to treatment, so we kept on surveillance, and we observed a decrease. And now she doesn't have any tumor left. So beyond the diagnosis, I think that as we already see in the previous presentation, we should focus also on other issues, especially chronic, especially pain, and we usually advise patients to visit a chronic pain specialist if needed. Functional impairment can affect patients with extremity desmoid, and also quality of life can be worsening, and the psychological support can be useful in some patients. So back to the question, can active surveillance be considered an active treatment? Patient, I think that sometimes can disagree. Doing nothing is very difficult to accept, and we in everyday clinic we need to manage this type of thought about. Patients well informed are essential in the treatment strategy and alliance. Advocacy group plays a crucial role in information process and in developing a new paradigm of cure. And of course, we think that the centrality of the patient-clinician relationship can make a difference. And I would like to thank all of you, all our patients, and of course, all the advocacy group and all my colleagues.
Yes, thank you for the presentation. What do we know about why the tumor may spontaneously regress?
I think that we do not have a lot of information from the biological point of view. What we are thinking is that immune system can play a role. You know that spontaneous regression is a phenomenon that can occur also in other tumors, for example, in melanoma, but we do not have any evidence of this. We are working on this topic, hoping to have some new information on the behavior from the biological point of view and not just from the clinical point of view.
I was just curious, was there any correlation about any size of increase before it started to regress, or is there anything of that nature we're aware of?
Now, what we know is that a tumor less than, is intuitive, but less than 5 centimeters is more prone to decrease, but this doesn't mean that tumor bigger than 5 centimeters do not go under spontaneous regression.
Thank you.
Quick question. Is there anything being done on looking at lifestyle, like nutrition, fasting, anything like that, exercise, obesity levels, whatever?
So this is a common question from patients, not only desmoid patients, but also patients with tumor and cancer. We do not have any epidemiological data supporting specific diet regimen or exercise. What I usually say to my patient is that they should do what they feel. So if they feel better in a specific regimen, they can go on with that, but we do not advise specific diet or specific exercise. But we also suggest to go to the physiotherapist, not just for the desmoid in the extremity, but also in the trunk, in the abdominal wall, because there are an imbalance in the skeleton with a mass. And so we think that is a suggestion useful without any clinical data on this.
Were there differences that were significant in regression spontaneously for progression or for regression after progression with FAP versus desmoids that were sporadic?
As Bernd said before, FAP patients are different. We have some patients we just observe, and it depends on the site, of course. It depends on the size and depends on the behavior. Since we are used to follow them very strictly, we can anticipate eventually the treatment, but there is space also for FAP patients and for the active surveillance. I just want to add one thing, because we think that the most important part of treating desmoid patient is to impact on their quality of life less than the desmoid usually does. So this is the reason for why we discuss a lot with patients about which kind of treatment, if needed, we can propose.